understood with GLP. And of course, incretin response is preserved in type 2 diabetes. I will explain this last point in a graph. So basically, in the postprandial period, what insulin secretion is doing is it's stimulating whatever normal insulin actions are in the body. Its glucose is taken up by the liver and stored as glycogen. In the muscle and fat cells, it's transported and stored for further use. It facilitates amino acid uptake and formation of proteins and promotes the conversion of glucose into glycerol. So that was in a nutshell a little bit about some of the pathophysiological aspects of type 2 diabetes. Now I'd like to take you to what is actually the incretin effect and why incretins came into such a forefront in the last few years. Now there was a scientist called Nock who has demonstrated this incretin effect, and this paper was published in Diabetologia in 1986 actually. Now this man has shown, he's given normal people an IV glucose load, and he's given half of them an IV glucose load and half of them he's given an oral glucose load like your OGTT. So you have the yellow, or if you're seeing, you're probably perceiving it as green. The IV is the green and the oral is the red. Now conventionally, we like to believe as doctors that anything given IV has got the maximum action. But this was not the case with oral glucose. This scientist has shown when glucose was given IV, the amount of insulin that was released from the beta cells in response to this IV glucose was not as much as was released in contrast to the oral glucose load. So you can see the amount of insulin that was released when glucose was given orally. That was quite high as opposed to when it was given IV. Now this difference he has termed as the incretin effect, because this further studies have proven, and even in the paper he's mentioned, this is because of the presence of the gut hormones or the incretins which are released after you take food orally. This is not there when it's given IV. It's only in response to oral glucose. So this difference is known as the incretin effect and is the basis for all the incretin therapies in the market, whether you're using a gliptin or a GLP-1. Either ways, this is the basis. He's taken this a step further and he's shown that in type 2 diabetes patients, when he's done the same thing which he did in a normal patient, this incretin effect was lost. Now, a lot of people would like to argue over here, which I get a lot in my dealings with doctors on a 1:1 level, is anyway in type 2 diabetes insulin level is reduced. So this obviously had to happen. But the point over here is, even though insulin level secretion is reduced in type 2 diabetes, which is absolutely correct, so overall the graph would be flatter, but the difference between the graphs should have remained the same. The difference. I'm not talking about the absolute levels, I'm talking about the difference. Because the incretin effect is actually the difference in the area under the graph, not the actual values. So even in a type 2 diabetic patient, as opposed to given IV or oral glucose, the difference should have remained the same, but it wasn't the case. The difference also reduced. This has led him to conclude that in a type 2 diabetic patient, overall incretins are deficient. There is a loss of the incretin effect, specifically GLP-1, in type 2 diabetes, and this is what he's proven. Taking it further, a study which was published in JCEM, this has shown 3 sets of patients, one normal set, one set of patients with impaired glucose tolerance, that's IGT, and one set of patients with type 2 diabetes. Now what they were given a meal, and their postprandial absolute GLP-1 levels were measured in the blood. Circulating endogenous GLP-1 levels were measured in the blood after giving a meal. And I think it's pretty self-explanatory from this graph. The NGT is somebody who's normal, so you can see he has high levels of GLP-1. A person with impaired glucose tolerance is in the pre-diabetes phase. He had definitely had a reduction in the circulating GLP-1s, and definitely a person with type 2 diabetes is even further reduced as compared to even an IGT. So this has been proven with Dr. Knox's theory that postprandial GLP-1 levels are decreased in people with pre-diabetes as well as type 2 diabetes. So this is one defect which the incretin therapies are trying to replenish with the current available drugs. So the abnormal incretin effect in type 2 diabetes, there is a loss of the incretin effect which we have already established. This leads to postprandial hyperglycemia. As I've already told you, GIP-1 secretion is not affected much. It's normal, but it cannot stimulate insulin secretion. GLP-1 secretion is below normal in patients with type 2 diabetes. And when you add GLP-1, its effects on the beta cells are similar to those of people without diabetes. And this graph shows that. Now what we have done over here is we have given continuous IV GLP-1 infusion to two sets of patients. One was a control set and one with the type 2 diabetes. We have given continuous IV GLP-1 infusion from outside and we have measured blood glucose levels. This was the control and this was the type 2 diabetic. When these type 2 diabetics were given GLP-1 infusion, their glucose levels almost reached the control people's values. So this we have tried and elicited that normalization of diurnal plasma glucose can be achieved by continuous IV GLP-1 infusion. But again, in regular routine clinical practice, we cannot give IV GLP-1 infusion constantly. That would require the patient to be admitted, and that's always not feasible. So we have taken it a step forward and we've tried to make it a once daily, maybe subcutaneous injection, and that's where Liraglutide has come in. What are the other therapeutic effects of GLP in people with type 2 diabetes? There's been a reduction in there's been a reduction in glucose levels, there's been a reduction in glucagon levels, and an increase in insulin levels as measured by C-peptide. I think I do not need to tell the learned audience over here that C-peptide is the connecting chain which breaks off from the pro-insulin structure when insulin is released. So pro-insulin breaks down to insulin and C-peptide. Insulin levels have to be measured by RIA. It's a little bit more difficult and cumbersome. It's relatively easier to measure C-peptide levels in blood to give you an indication of insulin levels that are being secreted. So if C-peptide levels are going up, it will give you an indication that insulin levels are also going up. Certain studies done in diabetic fatty rats, again this I'd like to just tell you is only in animal studies, and how it translates into humans. Again, we have a study plan for the same. There was an increase in beta cell mass, there was an increase in beta cell proliferation, and there was a reduction in beta cell apoptosis. All this was shown in diabetic rats. So this gives an indication that there is a positive effect on beta cell function as well. And earlier on in my presentation, I have kind of established that the loss of beta cell is something which starts even before the person becomes diabetic. So if there is a way, if there is a molecule which can help preserve your beta cell function along with giving you the glycemic control and certain extra glycemic parameters benefited, then that should be ideally the good molecule or an ideal molecule to give your patient. So to give you a summary of the incretin effect, GLP-1 and GIP are the major incretin gut hormones which are released in response to food. They both enhance insulin secretion from the beta cells in a glucose-dependent manner. GLP-1 further suppresses glucagon release from the alpha cells. The incretin effect is attributed to these incretin hormones which are derived from the intestines. We have established that the incretin effect is diminished in type 2 diabetes. Here again, GIP is not a therapeutic target. It's never taken forward in any company's clinical trials. Only GLP-1 has been the target area for type 2 diabetes. So how does this all translate into humans? We've seen some physiological things, some pathological things, some things in rats, So what happens in humans? After food ingestion, GLP-1 is secreted from the L cells of the jejunum and ileum. This, in turn, stimulates glucose-dependent insulin secretion, suppresses glucagon secretion. Apart from these two, which we have already established, it slows gastric emptying time. Perhaps this is one of the reasons why there is a reduction in food intake. There is also an improvement in insulin sensitivity, and long-term effects in animal models, which I've already discussed, is an increase of beta cell mass and improved beta cell function. So how do we stimulate GLP-1 based therapies in clinical trials? How do we get it into the market? There are two ways. Endogenous GLP-1, circulating endogenous GLP-1 is broken down by an enzyme known as DPP4, dipeptidyl peptidase 4. This causes endogenous GLP-1 to have a circulating half-life of 1.5 to 2 minutes only. So as soon as it's released in response to food, it's broken down within 2 minutes. So how can we increase GLP-1 levels in the body? There are two ways. Either you give GLP-1 agonists exogenously, or you block the DPP4 enzyme, which is breaking down endogenous GLP-1. And this is what is written over here, right? So when you're giving a DPP4 inhibitor, it is enhancing the effect of endogenous GLP-1. And hence, DPP4 inhibitors are also called incretin enhancers. But when you are giving a GLP-1 analog from outside, you are mimicking the effect of endogenous GLP-1. So it is called an incretin mimetic. This is the basic difference between a GLP-1 and a DPP4 inhibitor. So there is an incretin mimetic and there is an incretin enhancer. Right, so we have the GLP-1s which are available in the market are exenatide. It's available as a twice daily preparation. It's available as a once weekly preparation. We have Liraglutide, which is available as a once daily preparation. There's many more which are upcoming in the market, like Liraglutide, lixisenatide, which has recently received approval, I think, in the European Union. Then we have the DPP4 enzymes, and quite a hot favorite with all the doctors these days, primarily because it's oral. Sitagliptin, the pioneer molecule, time tested. Vildagliptin, the latest in the market being linagliptin. Of course, there are others, there's Saxa, there is alogliptin as well. Now, the question is, why would we use liraglutide and not a gliptin?